Welcome back to the deep dive. So our mission here, it's really to take the critical research, the complex stuff, the data you really need to know, and break it down, make it actionable. And today, well, we're diving into a real challenge in oncology. It's about managing bone health and prostate cancer.
Yeah, it's fundamental, really. When prostate cancer spreads to the bones, whether it's MCSPC, that's the castration-sensitive kind, or the later stage MCRPC, well, using bone-modifying agents, BMAs, it's just not optional. It's essential care.
Right, essential because they stop these things called skeletal-related events, SREs. And these are, they're really awful complications, aren't they?
Yeah.
Fractures coming out of nowhere, the spinal cord getting compressed, needing urgent radiation just for the bone pain. Denosumab specifically, it's this incredibly powerful drug that helps protect the bones, helps patients live better.
Absolutely. That's the upside, a huge upside. But like any really effective treatment, there's always a potential downside, a trade-off. And with denosumab, the main concern, the shadow, is something called medication-related osteonecrosis of the jaw, MRO&J.
MRO&J.
And this isn't minor. It's potentially really debilitating. You get this exposed bone in the jaw, dead bone that just won't heal. It hits quality of life hard, causes pain, can make eating difficult. Sometimes it even needs, quite invasive surgery. It's a real problem for patients and doctors.
And figuring out the actual risk, how likely this is to happen, it's been tricky, hasn't it? A lot of the data we had was maybe short-term or from smaller studies, or it kind of lumped denosumab in with older drugs.
Exactly. The picture was murky.
But that's changing now. We're going deep today into this major real-world study from 2025. They tracked 624 prostate cancer patients, all on denosumab, long-term. And what it shows about the cumulative risk, how it builds up over time, and the specific things that increase that risk. Yeah, well, it's pretty eye-opening. Transformative, even. Okay, so let's unpack this. Maybe start with the basics. Why did denosumab become the go-to choice over the older drugs, the bisphosphonates?
Right, good place to start. The shift towards denosumab really comes down to two main things: how it works and its safety profile, particularly regarding the kidneys. Denosumab itself, it's what we call a fully human monoclonal antibody, very targeted.
Okay, monoclonal antibody and its target.
It goes after something called ARNKL, that's a receptor activator of nuclear factor kappa B ligand. Bit of a mouthful.
Okay, ARNKL. So what does hitting ARNKL actually achieve in the bone? Let's simplify that a bit.
Sure, think of ARNKL as like the go signal. It activates these cells called osteoclasts.
Osteoclasts. Those are the ones that break down.
Exactly. They dissolve bone tissue. Now, in advanced cancer, the tumor cells can kind of hijack this system. They make the body produce way too much RNKL signal. So the osteoclasts go into overdrive, just breaking down bone like crazy. That's what leads to the SREs. Denosumab works by basically grabbing onto RNKL before it can deliver that go signal. It effectively shuts down that excessive activation.
So it's like cutting the wire to the demolition crew. Very precise.
Pretty much, yeah. Much more precise than the older standard, like zoledronic acid, which is a bisphosphonate, a BP.
Right. And how do those BPs work differently? What about their side effects?
Well, bisphosphonates, they sort of get physically stuck into the bone itself, into the matrix. Then, when an osteoclast comes along and starts trying to dissolve that bit of bone, it ingests the bisphosphonate, and the BP basically poisons the osteoclast, shuts it down. It works, but it's less targeted, and it has other issues. The source material points out two big wins for denosumab. First, clinical trials showed it was actually better at preventing SREs, just more effective.
Okay, better efficacy.
And second, and this is a big one, zoledronic acid is almost entirely cleared out by the kidneys. A lot of patients with advanced cancer, especially older folks, might have kidney function that's not 100%. So the drug can build up, potentially causing kidney damage. Denosumab doesn't really rely on the kidneys for clearance, so it avoids that whole issue. Much safer from a renal perspective.
Okay, so it works better, and it's safer for the kidneys. It's easy to see why it took over. The study we're looking at mentions, I think, that where they did the research, like 659 patients got denosumab since 2015, and only 4 got zoledronic acid. That's like a complete switch.
It is a near total replacement in many places, which, circling back, brings us to that trade-off again. Denosumab might be kinder to the kidneys, but those early, maybe smaller studies started to hint. Because it's so potent at shutting down bone turnover, it might actually carry a slightly higher risk of causing that jaw problem, MRO&J, compared to the bisphosphonates. That was the suspicion, the knowledge gap.
Right, a gap this new study really aimed to close.
Precisely. Because we needed data from a large group focused only on denosumab in this specific cancer, followed over a long time. Real-world data.
And that's what this 2025 study delivers.
Exactly. It's retrospective, looking back at 624 prostate cancer patients with bone mets treated between 2015 and 2024. The average follow-up was 20 months, and patients were on denosumab for a median of 14 months. But critically, they followed patients for much longer, too, allowing them to see these long-term effects. The dose was the standard 120 milligrams, usually given every 4 weeks to start.
So the scale, 624 patients just focusing on denosumab in prostate cancer.
Yeah.
That gives it real weight, doesn't it? More power than maybe some of the earlier work.
Absolutely. It lets us see what happens outside the sort of clean room environment of a randomized trial, what happens in the real clinic over years.
Especially for patients who are surviving longer with the disease now.
Yeah.
Okay, here's where it gets really interesting. Let's dive straight into the headline numbers. The cumulative incidence. You said 624 patients? What did the risk of getting MRO&J look like as time went on?
Well, the pattern is the really stark thing. It's not flat. It climbs steadily and steeply the longer patients are on the drug. So after 1 year of treatment, the cumulative chance of developing MRO&J any stage was already 4.6%.
4.6% at 1 year.
Right.
That's maybe already a bit higher than some might guess based on old trial data.
I think so, yes. But look what happens next. By the 2-year mark, that rate basically doubles. It hits 9.6%.
Wow, okay. Doubling in a year.
And then at 3 years, you cross a really significant line, 20.3%.
20%. So 1 out of every 5 patients still on denosumab after 3 years had developed MRO&J in this cohort.
Exactly. 1 in 5. That's already a major clinical consideration. We need to pause on that.
Definitely. But the study followed patients for longer than 3 years. What happens to those who are, the long-term responders, the survivors on treatment for 5, 6 years or more?
This is the number that just completely changes the risk calculation. It's the real shocker from the study. By 6 years on denosumab, the cumulative incidence rate of MRO&J reached 51.9%.
50. Wait, say that again.
51.9%. More than half. Over half of the patients who were on denosumab long-term in this real-world group developed osteonecrosis of the jaw.
My goodness, that changes everything about how we should be talking to patients about this drug long-term. It means MRO&J isn't some rare side effect for long haulers. It's actually more likely than not.
It becomes the expectation, not the exception, for those who stay on therapy for that long.
Okay, and that 51.9% includes all stages, mild to severe. What about the really bad cases, the severe MRO&J, stage 2 or higher? The ones causing major pain, infection, needing surgery.
Right, because that's often what drives the most significant impact on quality of life. Stage 2 or 3 by the ARMS definition means you've got exposed bone, plus definite signs of infection, pain, sometimes pus draining. It's serious.
So the rates for those severe cases?
They also climb worryingly. At 1 year, severe MRO&J was 2.4%. By 3 years, it was up to 13.1%. So more than 1 in 10 patients by year 3 had severe jaw necrosis.
13% severe at 3 years.
And then at the 6-year mark, the cumulative incidence of severe MRO&J hit 27.9%.
28%. Nearly 1 in 3 patients on long-term denosumab develop severe, potentially debilitating jaw necrosis.
That's the reality this study presents. 1 in 3 severe cases at 6 years.
This is it's staggering when you compare it back to the numbers we usually hear quoted from the big randomized controlled trials, the RCTs, that got the drug approved. Weren't those rates something like, 1.3% and maybe 3.2% at 3 years? How do we explain this huge gap from maybe 3% in trials to over 50% overall, nearly 30% severe in the real world at 6 years?
It's a massive difference, isn't it? And it really highlights why we can't just rely on those initial highly controlled trials for long-term safety, especially for side effects that accumulate over time. There are probably a few reasons for this disparity. First, think about who gets into an RCT.
Right, they tend to be ideal patients in some ways.
Exactly. They often exclude patients who have other health problems, maybe pre-existing dental issues, those on lots of other medications. Basically, they filter out many of the factors we now know increase MRO&J risk. The real world is just messier. Patients are older, they have more comorbidities, they might have borderline dental health to start with.
So the population in this real-world study is probably just inherently higher risk, and they were followed for longer.
That's almost certainly a major part of it. Longer duration of treatment allows that cumulative risk to really build up. The authors also mentioned something else. This study was done in Japan. They wondered if there might be some, racial or ethnic differences in how the drug is handled or in bone biology that could make MRO&J more common in that population. They referenced another Japanese study that also found a similarly high rate, around 50% at 5 years, so that's a possibility too.
Interesting point about potential population differences.
But the core message, I think, is universal. The way risk accumulates over years in a typical patient population receiving denosumab seems to be drastically underestimated by the short-term trial data.
Yeah, it feels like the standard risk-benefit chat we have in clinic might have been using a risk number that was just too low for a long time.
I think that's fair to say. Oh, and one other quick finding from this section. They looked at whether it mattered if the patient had metastatic castration-sensitive prostate cancer, MCSPC, or the later castration-resistant stage, MCRPC.
Ah, okay. Did it matter?
Nope. They found no significant difference in the rates of MRONJ between those two groups.
So it's not about the specific stage of the prostate cancer itself.
It seems not. The key driver appears to be simply being on denosumab, and for how long. Once you start the clock on denosumab, that risk starts ticking up similarly, regardless of whether the cancer is still responding to initial hormone therapy or not.
Right. Duration is king when it comes to this risk. Okay, so we've established the scope of the risk is much, much higher long-term than we thought. Now, the really crucial part, who is most likely to get it? We need to move from just describing the rates to identifying the specific factors that predict or even cause MRONJ. The study used Cox regression analysis, right, to isolate the independent risk factors.
Exactly. This is where we get the actionable insights. The statistical analysis managed to tease out three main factors that independently predicted a higher risk of developing MRONJ, both any stage and the severe stages.
Okay, let's break them down. Risk factor number 1, extent of disease, or EOD, grade geek 3-3. What does that mean?
EOD grade is basically a score, often from a bone scan, that tells you how much cancer has spread to the bones. Grade 3 or higher means it's extensive. Lots of spots, often involving the spine and pelvis, suggesting a really high burden of disease in the skeleton.
And having that extensive disease at the start, how much did that increase the risk?
Quite significantly. Patients with EOD grade 3 or more had double the risk, a hazard ratio of 2.00 for developing any MRONJ. And for severe MRNJ, the risk was even higher, 2.5 times the risk compared to those with less extensive bone disease.
Okay, that's interesting. Why would having more cancer spread throughout the body make someone more likely to get a jaw problem? It's not like the cancer is usually in the jaw, is it?
No, rarely. It's not about local metastasis to the jaw. The hypothesis the study puts forward, which makes a lot of sense biologically, is about systemic inflammation. When you have that much cancer in the bones, EOD grade 3+, your whole body is in a state of sort of chronic high-level inflammation. The cancer itself and the bone breaking down releases all these inflammatory signals, cytokines, growth factors into the bloodstream.
Okay, so the body's generally inflamed.
Right. And remember, MRONJ is fundamentally a problem of wound healing failure in the jaw, often triggered by some local irritation or trauma. If your entire body's repair systems are already stressed and sort of dysfunctional because of this high systemic inflammation from the cancer, then that local wound in the jaw just doesn't stand a chance of healing properly. The inflammation might actually hinder the normal healing process, maybe promote more scarring instead of healthy tissue repair, especially in a challenging environment like the mouth.
Ah, okay. So the widespread cancer creates kind of hostile environment for healing anywhere, and the jaw is particularly vulnerable when denosumab is also shutting down the normal bone repair crew, the osteoclast.
You got it. It's a systemic vulnerability meeting a local challenge amplified by the drug.
Makes sense. Okay, risk factor number 2. This one seems more straightforward to check for. Use of anticoagulants, Anti-Dor antiplatelets, blood thinners.
Yes. And this was another strong predictor. Patients on these drugs had just over double the risk, HR 2.08, for any MRONJ. But again, the risk for severe MRONJ was even more pronounced. It almost tripled, with a hazard ratio of 2.96.
Wow. And a lot of older patients, especially those with prostate cancer, might be on these for heart issues or clots, right? Like warfarin or aspirin or heparin.
Exactly. It's a very common scenario. And this finding puts doctors in a tough spot because you can't just stop someone's essential blood thinner for their heart or to prevent a stroke.
So what's the proposed link here? Is it just about bleeding risk during dental procedures?
That might play a small role, but the study suggests something more fundamental. It's thought to be about how some of these drugs affect bone metabolism itself, particularly the vitamin K antagonists like warfarin. We know vitamin K isn't just for blood clotting, it's also crucial for bone health.
Really? How does vitamin K affect bone?
Vitamin K is needed to properly activate certain bone proteins, like osteocalcin, which are important for building and maintaining the bone matrix. So if you're blocking vitamin K with warfarin to manage clotting, you might inadvertently also be weakening the underlying bone structure. You're impairing its ability to mineralize properly and maintain its density and resilience.
I see. So the blood thinner isn't just thinning the blood, it might be subtly weakening the bone foundation itself.
That seems to be the idea. So you take this potentially compromised bone, then you hit it with denosumab, which stops its normal repair and remodeling cycle, and then maybe add a bit of local trauma. The whole system just fails catastrophically, leading to that non-healing necrotic bone.
So it's not just about bleeding, it's a deeper structural compromise. That explains the link much better.
Yeah, it's thought to be more about the bone quality itself being affected. It's a synergistic hit. You can imagine a patient with expensive disease, EOD3+, who's also on warfarin. Their risk profile for severe MRONJ is suddenly looking incredibly high.
Definitely a high-risk combination. Okay, on to the third independent risk factor, and this one feels like something we should have more direct control over. A history of dental treatment within the past 6 months.
Yes, and this actually had the highest hazard ratio for predicting any stage of MRONJ at 2.29. The risk for severe MRONJ was similarly high, HR 2.98.
So almost tripling the risk if you've had recent dental work. This really backs up the standard advice, doesn't it?
It absolutely does. It confirms what we've suspected and what guidelines recommend. Local factors in the mouth are critical triggers.
So the first two factors, the extensive cancer and the blood thinners, they sort of set the stage, create the vulnerability.
Right, they create the susceptible patient.
And then the recent dental work, or maybe even just poor oral hygiene causing inflammation or minor trauma, that provides the spark, the trigger point.
Precisely. Things like a tooth extraction, maybe deep gum scaling, even just an ill-fitting denture rubbing constantly. These things breach the protective mucosal barrier, introduce bacteria, and create a wound. In a normal mouth, that heals. But in a patient whose bone remodeling is suppressed by denosumab, especially if they have those other systemic risk factors, that wound just can't close. The bone gets exposed, infected, and starts to die off.
Which underscores the massive importance of prevention. Getting the mouth as healthy as possible before starting denosumab.
Absolutely critical. This finding really quantifies why that pre-treatment dental checkup and getting any necessary invasive work done before starting the drug is so vital. That 6-month window seems key.
You need to fix the roof before the rainstorm hits, essentially.
That's a good way to put it. Any required extractions, implants, major gum work, get it done, let it heal completely, then start the denosumab. And ongoing meticulous oral hygiene is paramount.
It really pushes towards personalized risk assessment, doesn't it?
Yeah.
You see a patient with EOD grade 3 on warfarin who just had a tooth pulled last month. That person needs a very different level of monitoring and maybe a different treatment approach.
That's the highest risk scenario imaginable based on this data. It demands intense vigilance and potentially altering the plan.
Okay, so identifying risks is one thing, hugely important. But the really exciting part, the part that offers a way forward, is finding something that lowers the risk.
Let's talk about the big takeaway here. Optimizing the dosing interval.
Yes, this is potentially the most impactful finding for clinical practice right now. It's something we can actually do to mitigate this risk. The study found a really striking association. Patients who received their denosumab shots at intervals longer than 1 month had a significantly lower risk of developing MRONJ.
Okay, significantly lower. How much lower are we talking? We're talking nearly cutting the risk in half. The hazard ratio for getting any MRNJ dropped to 0.46 for the extended interval group. And for severe MRNJ, the risk reduction was even slightly better, with a hazard ratio of 0.42.
Wow, hazard ratio 0.42. So roughly a 58% reduction in the risk of severe debilitating MRNJ just by spacing out the doses.
That's what this real-world data suggests. It's a huge potential benefit just from changing the schedule.
That's incredible for preserving quality of life. But okay, here's the big question, the immediate concern any clinician would have. Denosumab is given monthly for a reason, right? To stop those SREs, the fractures. If we start spacing out the doses, are we trading protection for the jaw for increased risk of broken bones elsewhere? Are we compromising the main reason we use the drug?
That is the absolute crux of the matter. If extending the dose interval meant more fractures, it would be a non-starter for most patients. But here's the other killer finding from this study. They specifically looked at that. They compared the rate of SREs fractures, spinal cord compression, need for radiation between the patients getting monthly doses and those getting it less often.
What did they find?
No statistically significant difference. The p-value was 0.99, meaning essentially zero evidence of a difference in bone protection between the groups.
No difference in SREs.
Right.
That's huge. That removes the main barrier to adopting this strategy.
It really does. It suggests that, at least in this large real-world cohort, extending the dosing interval significantly lowered MRO-NJ risk without losing the crucial benefit of preventing fractures and other skeletal events.
Why would that be the case? If the drug is designed for monthly dosing based on its half-life and mechanism?
It probably comes down to the sheer potency and duration of effect of that 120 milligram dose. Denosumab binds very tightly to Aring and KOL, and the suppression of osteoclast activity it causes might just last a lot longer than 4 weeks in many patients. Especially once the initial bone disease is under better control, the baseline rate of bone turnover might be lower. So giving another big dose every 4 weeks might be therapeutic overkill. You're achieving profound, sustained suppression that maybe lasts closer to 2 or 3 months anyway. The extra doses within that window might only marginally improve SRE prevention, if at all, but could be significantly adding to that cumulative exposure that drives the MRO-NJ risk.
So the standard monthly dose might be delivering more drug than needed for bone protection long term, but just enough extra to really ramp up the jaw toxicity over time.
That seems to be the implication of this data. We might be able to achieve nearly all the benefit with significantly less risk by just easing off the frequency after an initial period.
Reducing the risk of severe MRNJ by nearly 60% without losing bone protection.
Yeah, you said it before. That's a game changer for managing patients long term.
It really is. And the study gave some context on the intervals used. Most patients in that lower risk extended interval group weren't getting it, say, every 6 months. They were typically receiving it around every 2 to 3 months.
Okay, so maybe 8 or 12 weekly rather than 4 weekly.
Exactly. Which, of course, means their total cumulative dose of denosumab over several years would be substantially lower than someone on a standard monthly schedule. And that cumulative dose seems to be the key villain for MRNJ.
This puts doctors in an interesting position right now, doesn't it? Because the official guidelines from groups like ASCO, ASMO, they still generally recommend the every 4-week schedule, especially for the castration-resistant patients, MCRPC.
They do. The guidelines are based primarily on the original RCTs that use the 4-week schedule. So this new real-world evidence creates a direct tension with those established recommendations.
What should clinicians do with this information now? Well, ethically, I think it means we have a responsibility to discuss these findings with patients, especially those facing potentially years of therapy. We need to talk about the 51.9% 6-year risk seen in this study and the strong signal that extending the interval seems safer without compromising SRE protection. It really argues for moving towards more personalized dosing schedules right away, particularly for patients identified with those other risk factors like high EOD or being on anticoagulants, rather than waiting potentially years for guideline committers to formally change recommendations.
And this study strongly validates the need for the clinical trials that are already underway looking at this specific question, right?
Absolutely. The authors mentioned one trial specifically, NCP 0205118, which is formally comparing the standard 4-weekly dose against a 12-weekly dose. This real-world study basically provides powerful supporting evidence that such trials are not just necessary, but that the hypothesis that extended dosing is feasible and safer is likely correct. It shows it's already happening in practice and appears to be working.
It really paints a picture of future practice, doesn't it? Maybe you treat aggressively monthly for the first 6 months or a year to get the bone disease under control.
Right, an induction phase, perhaps.
And then, once things are stable, you could transition to a less frequent, maybe 12-weekly maintenance schedule to keep the protection going, but dramatically lower that long-term MRNJ risk and improve quality of life.
That seems like a very logical and evidence-supported approach based on this study. The risk seems to build with that relentless month-after-month suppression. Giving the jawbone a bit more recovery time between doses might be key.
Okay, so stepping back.
Yeah.
What does all this tell us? Let's try to tie it all together. The high risk, who gets it, the dosing solution. How does this refine our understanding of why MRNJ happens in the first place?
I think it reinforces the multifactorial hit model. MRNJ isn't caused by just one thing. It's like that perfect storm analogy. Denosumab sets the stage by creating this environment in the jaw where bone turnover is drastically slowed down. The bone's normal ability to repair itself in response to minor injuries or infection is just switched off.
Okay, so the drug creates the vulnerable state.
Exactly. Then you need the other factors we identified. You need a trigger, that's the dental work, the poor hygiene, introducing bacteria or causing a small wound.
The local hit.
Then you have systemic factors that make the whole body less able to cope. That's the expensive cancer burden, EOD3+, driving up inflammation and impairing overall healing capacity.
The systemic vulnerability.
And potentially you have drugs like anticoagulants subtly weakening the bone structure itself, making it less resilient even before the trauma hits.
The compromised foundation.
You put all those together, the suppressed turnover, the local trigger, the systemic inflammation, maybe the weakened bone matrix, and the system just breaks. The wound can't heal, bone dies, infection sets in, MRO-NJ develops.
It's a cascade. Makes sense. Now, one interesting point from the study was why patients actually stopped taking denosumab. Given this incredibly high long-term risk, you'd expect MRO-NJ itself to be a major reason for stopping. Was it?
Surprisingly, maybe not as much as you'd think based on the incidence rates. The study found that only about 16.4% of patients who discontinued denosumab did so specifically because they developed MRO-NJ.
Only 16%. What were the more common reasons then?
The most common reasons were actually described as passive. Things like patients finding it too difficult to get to the clinic for their monthly injections that accounted for almost 23% of discontinuations. And sadly, patient death was the reason for stopping in about 17% of cases.
So logistical hurdles and the progression of the underlying cancer were bigger drivers of stopping than the side effect itself.
It seems so, which suggests that if a patient is well enough and can physically get their shot, the treatment often just continues on that monthly schedule, potentially marching them towards that 50% plus risk without intervention.
That really reinforces the need for clinicians to be proactive about discussing and implementing risk mitigation, like extended dosing. We can't just wait for the problem to occur.
Exactly. And interestingly, extending the dosing interval might help with both issues. Fewer clinic visits makes it logistically easier for patients, and it dramatically lowers the MRO-NJ risk. It could be a win-win.
Definitely seems like it. Now, we always need to look critically at any study. This was retrospective, real world. What were the main limitations we should keep in mind?
The authors were good about pointing these out. Probably the biggest gap from a clinical perspective is that the study tells us how often MRO-NJ happened, but not much about what happened after diagnosis. We don't have long-term outcome data for those patients who developed MRO-NJ. Did it get better quickly with treatment? Did it stabilize? Did it become a chronic, persistent problem requiring ongoing care or surgery? That information is missing.
So we know the risk of getting it is high, but the study doesn't fully tell us the long-term burden or morbidity associated with it once it develops.
Correct. That's an important missing piece for fully counseling patients. Another limitation is just the nature of real-world data collection. This involved patients across multiple clinics, likely diagnosed by different dentists and oncologists using the standard AAOMS staging criteria. While those criteria are established, there's always going to be some variability in diagnosis and staging when you have multiple practitioners involved, especially for milder early-stage cases.
Right, less controlled than in a single protocol-driven trial.
Exactly. However, even with those caveats, the sheer size of the cohort, 624 patients, and the very clear, statistically powerful associations they found, particularly for the risk factors and the protective effect of extended dosing, a hazard ratio of 0.42 for severe MRO-NJ with extended dosing is a very strong signal. These limitations don't really negate those core findings. The message is still incredibly clear and impactful.
Okay, so let's try to really crystallize the key takeaways from this deep dive for everyone listening. First, the cumulative risk of MRO-NJ with long-term denosumab use is much higher than previously appreciated from trial data. We're talking over 50% overall risk by 6 years and nearly 30% risk of severe disease. This is not a rare event for long-term users.
A sobering reality check on long-term risk. Second, we now have clear independent risk factors identified from this large cohort. These are extensive bone disease, specifically EOD grade 3 or higher, suggesting high inflammation, concurrent use of anticoagulants or antiplatelets, possibly affecting bone metabolism, and crucially, a history of recent dental treatment or, by implication, poor oral health acting as the local trigger. Patients with these factors need heightened awareness and monitoring.
Okay, high risk established, key predictors identified, and the third, most actionable point.
The most actionable point is the strong evidence that extending the denosumab dosing interval beyond the standard 4 weeks, likely to around every 8 to 12 weeks, appears to nearly halve the risk of MRO-NJ. And critically, this study found that doing so did not seem to increase the risk of skeletal-related events like fractures.
So a potential path to dramatically reducing a major toxicity without compromising the primary benefit of the drug. This really calls for immediate action in clinics, doesn't it? comprehensive dental screening before starting, aggressive oral hygiene throughout, and a serious personalized discussion about moving to extended dosing intervals for patients on long-term therapy, especially if they have those known risk factors.
Absolutely. It's about proactive prevention and personalization based on this compelling real-world evidence.
Okay, so we've covered a lot of ground. High risk, predictors, a potential solution. Now, for the final provocative thought we'd like to leave you with, this study gives strong support for extending the denosumab dose interval that cuts MRON-J risk, seemingly without harming SRE prevention, but it doesn't definitively tell us the perfect new interval. Is it 8 weeks? 12 weeks, maybe something else. The big clinical trial comparing 4 weeks versus 12 weeks is still ongoing. So here's the question. Given the potentially devastating life-altering risk of severe MRON-J shown in this real-world data, nearly 1 in 3 long-term users, how should doctors balance things right now? Should they immediately start using extended intervals for many patients to protect quality of life based on this strong observational evidence? Or should they strictly adhere to the current guidelines and wait, potentially years, for the perfect RCT data, knowing the high-risk patients face in the meantime? How do you weigh that immediate observed risk against the desire for ultimate scientific certainty before changing practice? That tension right there is where clinical judgment gets really tough. Something to think about.
A very important question indeed, requiring careful, individualized discussion between doctor and patient, considering all the risk factors we've talked about today. Thank you for joining us for this deep dive.
We'll see you next time.